Hi, good afternoon. In the next few minutes, I'll talk to you about the importance of decision making and how it can take us a long distance to change the way we do healthcare in resource poor settings. Ladies and gentlemen, what does it mean to be born in India today? It probably means to be the part of one of the largest economies of the world by the 20th birthday. But before that, and beyond all, it means to be exposed to the greatest risk of not even making till the 5th birthday. India has one of the highest infant and maternal mortalities worldwide. 2/3 of us have to travel at least 30 kilometers before reaching a healthcare facility. 1/3 of us do not have access to specialist healthcare. We just have 0.6 doctors for 1,000 people in the country. Not surprisingly, this translates into a 7 to 10 years lag behind the Millennium Development Goals. We can still catch up, but with 600,000 new doctors. How big is that number? It compares closely to the total number of doctors we have in the country today. Therefore, I say this objective is breathtakingly ambitious. I went to one of the competitive med schools in the country and one of the oldest ones. During my experiences in the med school, I was internalizing two facts. One, that the village health worker is the heart and soul of our health programs. Whatever public health we do in the country, be it the National Rural Health Mission, be it the Vector-Borne Disease Control Program, or the AIDS Control Program, we solely depend upon the village health worker for its execution. Second, like inequalities in the distribution of food, inequalities in the distribution of money, there is also an inequality in access to intellectual abilities. Not that we are smart, but we had the fortune of training. The point that I was trying to make is I thought, what would be a way to empower the village health worker to take an appropriate decision? From here, I'll take you to a little more technical stuff. Now, this is about a 65-year-old lady who suffers from concurrent chronic illnesses. She's a diabetic, she's a hypertensive, she often has joint pains, she is often breathless of a chronic lung disease, and on top of that, she is an old heart disease patient. At any point in time, she takes around 12 prescribed medications. To encounter such a patient in our regular clinical practice, it is really not very uncommon. We do see such patients. Okay, let me ask you here, how many of you would agree with me that you have at least seen one such lady in your day-to-day life? I expected it is commoner than that. But anyways, what I want to say to you is, for a clinician, it's actually a nightmare to write such a prescription, wherein you have 12 drugs, all of them could react chemically, they could have an additive pharmacological effect, you got to look after the cost of the drugs, you got to dose the drugs in such a way so that the old lady has to reach out for her drug box minimum number of times a day. That is how you would increase compliance, otherwise she would not stick to your drug schedule. You got to look after cost and like many more factors. The point that I'm trying to make is this clinical decision challenge is clearly a complex one. So how do we stand up to it? Last year, while I was at the San Diego Supercomputer Center, we were involved in projects which were aimed at developing decision support systems for similar kind of situations. There were more complex ones, like how to decide when to wean a chronically ill patient from a ventilator, or how to judiciously weigh the risks and benefits of starting an anticoagulation therapy in a stroke patient. Realize there, So let's meet this second case wherein there is a mother who has come with a 3-month-old child to a village health worker in a primary healthcare center around us. The child is febrile for 2 days now. She looks to be short of breath and she is not feeding well. Now the village health worker got to tell us whether it is pneumonia or whether could it be meningitis. It could be an acute respiratory illness which could be treated on table. The village health worker got to tell us whether we need to record the temperature first or whether we need to count the breath first. And she has to do all this when outside her clinic, the picture is like this. She absolutely has no time to make the call. The point that I'm trying to make is the second clinical scenario is as complex as the first one. But because it is a case of a village health worker and it is a more basic case, a more basic patient that we are encountering in our day-to-day life, we probably don't see it in the same perspective. That was the moment of light for us when we realized that the complexity is not a sole attribute of the clinical decision challenge. It could arise because of mismatch between the demands of the clinical situation and the preparedness of the decision maker. And in the next few months, we set out to work on clinical decision support systems for resource-poor settings. We started up with the thrust areas, maternal and child health. We picked up WHO protocols like the integrated management of neonatal and childhood illness, like the antenatal protocols endorsed by the National Rural Health Mission Government of India. We made decision trees out of them. We had software engineers, like we were 4 friends to start with, who coded that into software. We experimented with a lot of hardware devices, beginning with a custom-made hardware device to a mobile phone and a PDA. And then we trained the village health worker how to use it. The interface was available in vernacular language, in this case Tamil. The project was called Project Amrita, and we started up with a funding from the National Rural Health Mission Tamil Nadu. Amrita in Sanskrit means the elixir of immortality. So basically we had a patient interactive interface wherein the village health nurse was encountering a patient and she had to feed in a number of basic data like history and the physical examination data. At the end of the encounter, the device in the front end itself was able to process this data into an essential decision about the provisional diagnosis and what would be the emergency management step that the village health nurse should take at the doorstep. There are certain things like this one, the weight monitoring of other quantitative parameters across 9 months of pregnancy, or maybe the dose calculation. Everything was taken care of by a decision support system. The field trial was rolled out in a couple of PHCs near Chennai, Neemam and Thirunendrayur, and the device plus the village health worker, surprisingly and to our fortune, performed as good as the state-of-art clinician decision. And greater than 80% of the people enrolled in the project agreed that such a decision support system had a long-term value in the way we did healthcare. This is one of the pictures in front of one of the PHCs we were working. So when you generate so much of electronic data, we get the data when there is connectivity, we get the data back to a back end wherein we have a central server, we analyze the data and we raise reminders and alerts. We can raise alarms if there is an outbreak. So things like real-time biosurveillance, health information management, jargons, all of that happen. So basically what we were trying to do is set a robust filtration and referral mechanism using technology. This is one of the pictures while probably we were traveling to a village. I would be taking the picture, I will be taking the photo. So what I was seeing here, I'm really thankful to these medicos. I mean, like, the worst part of being in a competitive school is the competition itself. They were ready to invest time on something as experimental as this when their friends were preparing for the competitive exams. Anyways, this is one slide I thought I would share with you. It is pretty old in the natural history of the company, which would be dating 3 years back. It must have been written, I just encountered this while I was researching material a couple of days back. It must have been written at a point where we were on a high, after winning a business plan event maybe, or we were literally high. I would read it out to you. Water is not as ubiquitous as air. Healthcare today is like water is to man. Essentially, there is an exclusion of many people. At Newdyne, we thought we would empower the village health worker with the ability to take the correct decisions. We would increase the accessibility and the outreach. And that, in our way, would be a step towards airifying health. Thank you.
Thank you, Dr. Saurav. I think, the recent trends in giving and making a change and impact has been that give more and select a small area where the impact can be more. So is that something that you're thinking of in New Dime? Is there an area that you're focusing on to get most impact, or is it widespread? How is your plan to get New Dime out?
Right. So basically, I personally want to be a cancer scientist,
Okay.
and I'm probably going to do my residency from the next year.
Okay.
So as of now, I basically believed in proving the concept that a product like this had a promise. We have a venture now. We are trying to build it up as much as possible. Hopefully, it grows up and it replicates around in the country, and it brings about the change. Why in the country alone, in the whole of the developing world?
That's wonderful. Do you think some states are doing better? You're from Bhubaneswar,
Yes,
and
yes.
you
So
studied in Tamil Nadu, and what is your impression on how the states are progressing?
So we are operating. We've shifted the operations. Now, Tamil Nadu is one of the best performing states under National
so?
Rural Health Mission.
Okay.
At least there should be a clap for this. And we have shifted our operations to Orissa, and we are operating in a couple of districts which are probably the worst health indicators in the world, Koraput and Kalahandi. So yeah, hopefully things change there.
Thank you so much. We have a long way to go. Thank you.